Febrile seizure. Febrile seizure is a seizure usually occurring in a child aged from 6 months to 5 years or 16 months, precipitated by fever, usually of more than 38 degrees, arising from infection outside the nervous system in a child who is neurologically normal, and a seizure that does not associate with any metabolic abnormality. There are classification of febrile seizure. The first is complex febrile seizure. A febrile convulsion with one of the following features is said to be complex febrile seizure. If it lasts longer than 50 minutes, if it is partial or focal, more than one convulsion per episode of fever, or within 24 hours. If it recurs within 24 hours, we can call it complex febrile seizure. Simple febrile convulsion or simple febrile seizure is a seizure with all of the following features. An isolated generalized tonic-clonic seizure lasting less than 50 minutes and not recur within 24 hours. Recurrent febrile seizure is a seizure which is febrile seizure more than one episode. And febrile status epilepticus is a febrile convulsion lasting more than 30 minutes or a series of seizures without full recovery in between that lasts for 30 minutes or longer. When we see the prevalence, 2 to 5% of children have at least one febrile convulsion, and the peak incidence is between 12 to 18 months. Risk of recurrent febrile convulsion is around 70.1 will have one recurrence, 8.9 of them will have two recurrences, and 5.8 will have three or more recurrences according to one big study. Approximately 75% of recurrences occur within 1 year of the first febrile convulsion. The risk of recurrent seizure or recurrent febrile seizure increases by if a first febrile seizure before the age of 18 months, if there is a family history of febrile seizure or epilepsy, following complex febrile seizure, multiple seizure during the same febrile episodes, and having a short duration of fever or having a seizure with a fever of less than 9 degrees increases the chance of recurrence. The risk of developing epilepsy is after one simple febrile seizure, it is around 2 to 7%, and after a complex febrile seizure, it is around 10 to 20%. Risk of epilepsy increases by presence of neurological abnormalities or developmental delay before the onset of febrile seizure, family history of epilepsy, and a short duration of fever increases the chance of having epilepsy. When we came to investigations are not routinely indicated, but a blood glucose should be measured in all cases, and we should have to look for a focus of infection and send of appropriate tests as necessary. Urine analysis and chest X-ray should be considered if no obvious cause of infection is there. LP should be performed if there are signs of meningitis or child is systemically unwell, age less than 12 months, if a febrile seizure is a complex type, if no focus of infection is found, if a child is unvaccinated or partially vaccinated, and if a child took antibiotics before evaluation. EEG and CT are not helpful in most cases. When we came to management, we should have to treat the underlying problem, and the management is otherwise supportive, and we should have to ensure adequate fluid intake. We should have to teach family, we should have to explain the nature and the prognosis of febrile seizure, instructions about management of fever, and advise parents to use rectal diazepam or buccal midazolam for a seizure lasting 5 minutes or till they came to clinic. Thank you for watching.